Welcome to another episode of Dr. Rob, Pain Detective. I'm your host, Dr. Robert Pomahawk. Topic tonight, COVID-19. And my guest is Dr. John Kowalchuk. He's a former president of Osteopathic Physicians Surgeons of California, former chief of urology at Good Samaritan Hospital, and one of only 30 surgeons in North America performing gender confirmation surgery. He's also presently on the front lines of COVID-19 treatment. Cool thing about him as well, he likes to dive with sharks. How cool is that? And we're back. Dr. John, welcome to the show. Glad to have you here.
Good to be.
My pleasure. So let's talk about what we talked about like 3 months ago when we first met.
Exactly.
As compared to what's been going on now with COVID, considering you've been in the front lines for 3 months. Talk to me, what's going on?
So if you recall, 3 months ago, we talked about the fact that we have a mutual interest in making sure people become pain-free.
Yeah.
And we recognize the fact that narcotics and surgery is not always the answer. So one of the things that I've been dealing with are the pelvic pain syndromes. And we came to an understanding that we recognize that there's pelvic floor dysfunction. And as we were moving forward to try and put together the working plan for helping these people outside of these prescriptions, all of a sudden we get hit with this pandemic of COVID. And so then everything comes to a screeching halt. Everything shifts now into a society that gets put into a lockdown situation. And we have people who really have been still suffering from pain, who people are still suffering from now the emotional effects of what's taking place here. And I think we agree on the fact that the emotional components can actually increase muscle tension, can increase the nerve stimulation, and can actually worsen a person's pain. So in these cases, we may have been having patients who are actually suffering worse than they were even before COVID without having been actually exposed to COVID directly. Indirectly, these are the consequences of what's taking place in society and healthcare.
And especially what you've been seeing patient-wise, because you still haven't been doing the surgeries, correct? As you said, you got a couple days off in between doing these surgeries, but for the most part, you're kind of able to continue to some extent?
Hospitals and surgical centers were given permission to continue doing surgical procedures on patients who we can keep out of the emergency room. Well, think about it for a second. If you're in the emergency room and you're coming in with pain, all of a sudden you have a room full of people that might have fever, cough, and shortness of breath. You can be getting exposed to a virus that can kill you. So the idea that we had placed in effect for the hospitals, which was given permission by state as well as federal legislators, is to go ahead and allow these people to have these procedures. Even though it's not life-threatening, it was still an idea to keep them out of the hospital. If we could actually keep them out of the emergency room, that was even more important.
Especially when you're talking about transformation, gender transformation, in terms of having to postpone these surgeries for a short time frame. Individuals were coming up emotionally to get ready for these surgeries. It's not like it's, you're moving appendix. You're changing someone's viewpoint of life and who they are from being a male to a female or vice versa. I mean, must have been interesting to have those conversations.
It's interesting you say that because the WAPATH, which is the World Profession for Health for Transgender Health, basically came up with a statement, a document, stating that for the transgender community, these surgeries were still considered essential and were considered part of the important surgical procedures that were necessary in order to keep people from having a hospital or an emergency room visit because of maybe some emotional upset, maybe some other issue that had come up. So we were still given permission to go ahead and do these surgeries. I'm not talking about a breast augmentation or facial surgery. I'm talking about actually the what we call the gender confirmation or gender reaffirmation surgical procedures, where we are really doing a lot of anatomical reconstruction from the waist down.
Sure. Now, were you also dealing with COVID patients at the same time as performing these procedures? Tell me about those experiences in this community who is, potentially HIV positive, AIDS, the gay community. Tell me how that was when it came to this autoimmune condition, compromised, and then having to deal with the virus and autoimmunity and things of that nature. What was going on there with your situation over the last 3 months?
So first thing is when you think about the patients, and some of our transgender patients are HIV positive with the concept that maybe they have immunocompromised status. So the fear was that if these patients actually got the virus or got exposed to the virus, that they would have a really horrible outcome. As you know, early on, we had all of these pieces of information coming mainly from Italy and Wuhan and then New York. A lot of people who ended up getting sick with high risk were dying. What ended up happening actually is, first of all, we put into place a protocol to make sure that they were not actually carrying the virus. So they had to get COVID tested before they had surgery. Secondly, when they were actually hospitalized, they were quarantined in a unit that was pretty much dedicated to other patients who may have had other surgical procedures. People were getting broken bones along the way. People were still having heart attacks. So most of the hospitals actually quarantined them, not because they might have had virus, but to protect them from other patients in the hospital that might have the virus. So we actually set up quarantined units for that purpose. Now, in terms of the community itself, one of the interesting factors that we found out is that very few of our transgender patients and very few of our HIV positive patients were actually getting symptoms of COVID. And as you remember early on, it was really hard to get tested. And if you didn't have symptoms, emergency rooms basically would treat you for your symptoms, tell you to go home and quarantine, and they wouldn't run the test. Now things are different. The tests are being opened up to all sorts of clinics as well as the clinic here. And what we're trying to do is actually find out how many people may have actually been exposed previously to the virus. But prior to that, we did not see as many of our HIV positive patients getting as sick as we thought they would. What we did find out is another population. A lot of our seniors were actually the ones, when they got the COVID, were the ones suffering from physical ailments requiring ventilation, being put on a respirator where they have to put a tube down into your lungs, put you on a machine to help bring oxygen into your lungs. Also, the patients may have had that needed this kind of treatment were patients who had diabetes, patients who actually had respiratory issues. And one of the things that we find out is a lot of these people who have respiratory issues may have what we call bronchitis or chronic obstructive pulmonary disorder, but some have restrictive lung disease. Restrictive lung disease can come from people who have problems where their chest is basically placed in a physiologic condition that doesn't allow full expansion and therefore aeration. These are people we're finding out were also having problems where they were ending up on these breathing machines, ventilators. And the majority at that time, early in February, at the end of February, early in March, most of these people were dying. So we didn't have a whole lot of ideas in order to help them. Here's a simple thing that did pop up, and this was something that has been used regularly in India, third world country for the most part when it comes to healthcare. But they were innovative many years ago, especially with SARS and with the H1N1, which is just as bad, if not worse. They found that if they were able to actually change the position of their patients, do what they call pronation, actually change them, put them on their belly, even while they're on the breathing machine, that would alter the physiology of the lungs, alter the ability of the ribs to expand, and maybe bring in extra oxygen and save a life.
Yeah, and that makes sense based upon, what I study is spine pathology and how it affects the autonomic nervous system, the sympathetic versus the parasympathetic nervous system. So it kind of goes hand in hand. And this is things that we've been researching and doing for about 20 years now. It's interesting how they are intertwining together to help people understand how respiration is not just a lung situation, but a postural base, a muscle dysfunction position, a structural dysfunction position. All those pieces are contributing and either helping the person overcome a lung condition or not. Tell me some scary stories that happened in the surgical room. Tell me some things that were unexpected. Did you have any of those events where like, wow, I've been a doctor for this many years, I'm following the right protocol, but for some reason this person's not responding? Did you have any of those whoa moments in the last 2 or 3 months?
There were many of those moments. I'll tell you the first actual experience is when I was called into the emergency room to actually take care of a urologic condition. And all of a sudden, at that same time, there was a person, what they call under suspicion. And that means we were thinking, but they didn't know they had COVID or not. They had the symptoms. And next thing you know, they went into respiratory distress. Here's my first exposure to the whole process. As I'm in the emergency room, you have to picture a team of people who are on this COVID team, and they're dressed in spacesuits, literally spacesuits, and there's sheer terror on their face. Remember, this is early March, where we don't have a lot of other information other than what's happening in Italy. And what was happening in Italy was frightening, and what was happening in New York was even more frightening here on our shores. And then you saw this team running in, sheer terror on their face. Now, what I failed to mention is that I actually trained as a trauma surgeon, and I switched along the way to urology. So what I learned in trauma surgery are chest compressions are life-saving. And for me to hear the team leader in the emergency room yelling out, "There will be no chest compressions," 3 times in a row, that really made me sad. And it really brought the entire focus on, this is a really dangerous virus that we're dealing with. It's really, everyone's afraid of it. The other things that took place is that as the time went forward, there were many of our older urologic colleagues who decided to take sabbaticals, because we found out also at a higher risk age, you don't do as well if you get the virus than some of the younger individuals. So a lot of our more senior physicians decided to take a time off. And there were very few urologists willing to come on board to help take care of patients that were suffering from COVID complications and the treatment of COVID complications as well. Some of the treatments, as you have heard with the treatment for preventing blood clots, are using blood thinners along the way. Well, blood thinners can cause lots of bleeding in the urinary system. Well, unfortunately, there are very few things you could do except manually go in there, put in tubes, and manually either take them into the operating room to get the bleeding controlled or flush them. So that's where people like me, who were asked to go on the front line and start making decisions on what medicines should and shouldn't be used in that individual. And that's basically a life-altering decision, because if you need it, you need it. However, you're dying from it, you have to say which one is going to actually kill you first.
Following protocols prior to the COVID situation, did that change post-COVID in terms of, what do I do here? I mean, I'm not quite sure what to do in terms of the chest compression. What was the premise behind that, or the purpose of not doing it, considering you just said that's a standard protocol?
So because of the fact that many of these individuals who are COVID positive, if you start chest compressions and they don't have a tube already into their breathing pipe, they will be actually projecting more of the virus. And so you could actually fill this room, one individual can fill this room with enough virus to infect everyone that's here, with the potentially life-threatening component, because of how much virus will be actually brought out into the atmosphere. So one of the things that they had developed were processes to put into place from that time to now, that if the person did need to have a compression of some sort, they would first have the individual that does the intubation go in to make sure the breathing tube is in place. Secondly, coverings would be placed over that individual, sometimes a plexiglass, depending on the hospital, and maybe a plexiglass box. It could be a plastic sheet to keep that patient's face from exposure to others. If chest compressions were necessary, then they can begin that. They also made decisions at hospitals that if you had a certain degree of medical conditions that were considered above and beyond, based just on simple knowledge of who's going to survive and not survive from February through March, then you basically would say these people would not be candidates for chest compressions. Obviously, a younger, healthier individual, you're going to do everything you can. Great story is, one of the hospitals I work at is the Hollywood Presbyterian Medical Center, where they were actually one of the first hospitals in the downtown region to actually start treating COVID positive patients. One of their nurses, who was heroic, went into a room with a young individual who ended up having a respiratory situation. She didn't go in with the proper protective gear, what we call PPE. And unfortunately, she was charge nurse, and she did what she was trained to do and get right there, right in front of everything, and start chest compressions, then recognizing she wasn't properly covered. She just reacted. And unfortunately, 2 weeks later, she died of the same condition.
Wow.
Now, the person that she actually helped treat survived. So she's a hero. Other things that we have to take into consideration is the fact that a lot of these people who are getting sick might be actually getting some of this respiratory situation worsened because when you're sick, you're hunched over
Or when you're stressed
and stressed.
or on your phone.
Correct. And if there are ways that we can possibly keep people to learn and treatments to do at home, even if you become COVID positive, if we could get them to start doing some of these simple exercises, we, at least in the osteopathic profession, believe that we can possibly keep some of them out of the hospital. And if we could keep you out of the hospital, that's important, number one. But number two, that also might mean we're going to be able to prevent you from having to be what we call intubated, getting
Sure.
that breathing machine. Because we already know that once you get intubated, even now, it's still over 50% death rate.
Wow.
The good news is that we are coming up with more treatments. It has become still a scary situation to walk in that room when you have to still dress up in full PPE. And we still recognize that the longer you're in that room, the surgeons like myself, if we have to take a person to surgery who's already positive, even with the spacesuits, et cetera, there's still a risk.
Chance. Yeah.
Yeah.
So what you're saying is there's simple things that people could be doing on their own to help improve the respiratory abilities.
Correct.
There's also simple things that people can be doing to improve their immune factors.
Oh, I'm glad you brought up immune factors. Here's something that I know that we're hearing from Washington with the use of certain medications that were used to treat malaria. And I'm going to be honest, in our hospitals, we're still prescribing that. Don't get me wrong. One of the things I don't think we're addressing, though, are some of the simple facts that we have been able to identify for the last decade with viruses, cold and other flu, are simple things like maximizing your ascorbic acid, which we call vitamin C.
Sure.
Using zinc, I wouldn't go overboard on zinc because you can cause metal toxicity, but zinc, making sure vitamin D is in your system. And if you can't gain access to vitamin D tablets for whatever reason, financially, let's use that as an example, because I do take care of a lot of people who are in financial bind. We live in Southern California. You have a natural source of vitamin D. You should be outside and absorbing that sun. One of the other things, I was just having a conversation with one of my students yesterday, and the student basically said, we've never been through this before. I contradict you, we have. Maybe you and I haven't because we weren't around, but in 1917 and 18, the world, the United States, went through basically the Spanish flu. It's the same process. We already know what's going to happen without a vaccine. We know roughly how long it's going to take for what we call a herd immunity concept. But what we also know is that being outside, if you look at the studies done back in 1918, which were crude studies, they were obviously showing that the patients who were not in the hospital, in those rooms, because they ran out of rooms like we had in New York. So they built tents here in Southern California. And you had these people out in the sun, and what we have is fresh air, and I'm sure the air was a little fresher back then.
Yeah.
But the point
Maybe not now, though.
Right?
Yeah.
The point I'm trying to make, though, is that these people that were outside, they thought were going to die. These people did better than the ones that were inside. But two reasons. Inside, there was no ventilation.
Got you.
And you had wards. So you had 12 people on each side coughing and spewing out and just recontaminating.
Sure.
Now you have these people outside, and you have the most natural, best ventilation, and that's called air.
Yeah, that's amazing. One thing that we've been doing at this office is antibody testing. And from my conversations, since I've been taking care of chronic pain sufferers for the last month or so, and having these conversations with the patients that have had the antibody testing coming back positive, they're saying how they felt sick in December and January and coming back from a trip. And it's very interesting to see how that's the very same story I'm hearing from the majority of people. It's like, I had something that was strange in those months, and now I find out that it was COVID. What are your thoughts about when it arrived, and just from now hearing people's stories and realizing that, wow, I kind of, am realizing that there's a lot of people that got this even in December when they were sort of having the flu, or, maybe stress from their family and tired and traveling and things of that nature. Then all of a sudden you're like, whoa, this was COVID.
Interesting you bring that up, because actually some of the earlier news clippings in China where early November, where they were actually describing that there was a new and a novel virus. And it was something that they were asking researchers from other parts of China to come and help them with their research in this area. So we already know that it was taking place at that time. We already know people were traveling back then. They probably were already exposing people in Europe, because if you look at the DNA of the actual patients who are affected here, mainly on the West Coast, we think that they're coming from China, but a lot of the actual virus is coming from Europe. So Europe had a more open relationship anyway with China. So it was probably taking place what we thought was the flu, the cold. And here's the other most interesting thing is that we found out now, we're saying anywhere from 25 to as much as 30% of people who actually have active virus are asymptomatic. So they're just carriers. And that basically...
But isn't that similar to the flu too? I mean, you could have an active flu virus and really have no symptoms. So, I mean, isn't that with most conditions? I mean, you can be suffering from a heart condition and have clogged arteries, but have no symptoms. For the most part, our body sympathetically in terms of having a response is one of the last things to show up, right? So in terms of not having a person with having the symptoms is very common along any type of condition you're treating.
Oh, absolutely. And those are silent. Those are like silent heart attacks.
Yeah,
silent
COVID.
Exactly.
Just like silent COVID, right?
Correct. Now, with this situation with the silent COVID, one of the things you have to remember, a lot of these people who we may be testing in the clinics right now, who have not had a single symptom, or maybe just had a sore throat, or maybe they just had a one-day fever, or they may have had, because we do know some of the stomach symptoms, such as nausea, vomiting, and diarrhea, can actually be a symptom of COVID. Red eye, conjunctivitis. We know 10% of the people who present with nothing more than conjunctivitis actually are COVID positive. So those are scenarios where people were coming in. I have a great story. Actually, one of my friends and her husband recently went to the Good Sam hospital to just get their test. She came back negative, and her husband is COVID positive. He has no symptoms. Well,
for the antibodies.
Well, it was actually the nasal swab.
Oh, wow.
It's the actual virus.
Actual virus, okay.
So she self-quarantined, he self-quarantined. He basically had no normal symptoms that you'd expect. But here's an interesting thing. His physician is actually one of these concierge docs.
Sure.
So he notified his doctor right away. His doctor sent him a care package. And it came the next day. The care package in there had blood pressure monitor, make sure your blood pressure's okay, a thermometer, check your temperature every day, and a little gadget that we call a pulse oximeter.
Yeah.
So the pulse oximeter actually showed that his oxygen was just barely normal, but he never felt short of breath. He never had a cough. But here's another interesting thing. We have this cytokine surge that takes place, which we know is the cause of most of these people who don't do well. And his heart rate was going above 100. Normally he runs in the 70s, and that's one of the symptoms of COVID. Now that lasted for 3 days, and then it disappeared.
So his resting heart rate increased by 30 beats compared to what it was naturally.
But he didn't notice it.
Sure.
So now we're way past what we would consider the contamination rate. So he's basically back to normal activity.
Wow. So lots of interesting stories that you've been able to see and hear. What we'll be talking about next is what I do in terms of pain management and how it correlates to improving your overall health by a couple things that most people don't know about. Posture, which we talked about already, but how the structural system interferes with the brain-body communication and how that interferes with neurological confirmation communication and how that also affects the potential of having COVID or just overall being healthy. So we'll talk about that when we come back on the show.
Great.
And welcome back. Just wanted to thank Dr. John for being here. Super appreciative of you being here. Glad to be working with you in terms of moving past COVID and taking care of all sorts of pain management patients. Looking forward to that. Thank you for being on the show.
My pleasure. I want to leave you with one tidbit. As we move forward, one of the things I have found that I admire about you are some of the things that you're using with posture and increasing ability to actually expand range of motion. Back in the TB crisis, when we had tuberculosis, one of the things that took place are the osteopathic physicians weren't allowed to actually entertain the patients in what we call allopathic hospitals. So we created our own TB asylums.
Huh.
Some of the things we used were real simple. One of them were basically trying to increase the thoracic outlet. Secondly, what we would call rib raising.
Okay.
Other things we did were basically using kind of like a chest compression, but it was actually a negative pressure. So these are things that we were using back then, and you have basically been able to modify in such a way using high-tech abilities and have these people actually have a potential to improve their own outcome in this crisis that's taking place today.
That's amazing. Thank you for that last tidbit.
I thank you.
I appreciate it. We'll talk to you next time. Cool. Thanks, Dr. John. Appreciate it. Welcome back. So now what I want to talk about is the things that I focused on for the last 18 years is looking at structural pathology and muscular pathology, also neurological pathology and soft tissue. Think about the top 6 things that make people more vulnerable to having COVID: age, obesity, heart disease, diabetes, smokers, and blood type. When you look at those 6 factors, 2 I can't do anything about. What we can do is discuss how to be healthier, how to reduce body fat. And so in our office, we actually analyze something called BIA, body impedance analysis, looking at lean muscle mass versus body fat, what type of body fat you have. Is it organ fat or is it muscular fat? We also look at where your body fat is. So if we have a baseline of how much percentage body fat you have, what can we do with that? So we have an implementation program here, once you're out of pain, to teach you how to properly exercise. We also discuss a 7-week regenerative medicine eating plan that helps you understand how to build your own growth factors, how to improve your health. Those are all really important lifestyle factors that we discuss here and handle here and teach. Now, when it comes to a couple different things, when it comes to the high blood pressure, the heart disease, the respiration, and Dr. John talked about how that's being affected. Imagine having structural pathology, forward head posture, and how it decreases brain blood flow. Not getting enough oxygen or blood supply into your brain because your brain and your body are not connected properly because you're having structural problems. And then even further than that, car accidents. Who hasn't had one? 90% of us have. That causes ligament instability and even increased problems when it comes to blood velocity. And then we talked about, the hunchback position that people are talking about with Dr. John, and how there's actually research peer-reviewed in top journals, blind studies and double-blind studies, indicating how respiration and forward head posture plays a role. So not only are we looking at pain, we're also looking at how your nervous system deals with overall health. And that's what we're also focusing on here. So when someone comes into the office and has neck pain, mid-back pain, it's amazing how their heart is also involved. Their lungs are also involved because structurally, you're going to have the nervous systems go into those parts of the body. And if that nervous system is under stress, guess what happens? Your heart's under stress and your lungs are under stress. And we're seeing that more and more these days with the introduction of more use of the phones, TVs, especially in this situation. So sitting up nice and tall, like your mom told you, is even more important these days. Now, when it comes to posture, we analyze posture here. So here's a healthy young man, right? You see the green line in that side perspective of this posture, that's where he's supposed to be. And then you see the red line. Okay, 2 things that we see here is hands are in front of him, rolling his shoulders forward, compressing his lungs like Dr. John talked about. And then his head is way forward. Okay, his head's supposed to weigh approximately 15 pounds based upon his height and his weight. With that forward head posture, his head now feels like it weighs 45 pounds. So an extra 30 pounds of pressure being placed on your structural system, muscles, but also lung capacity. It's like carrying around 3 more of these bowling balls around all the time. And you're not even doing anything, you're just standing, let alone exercising and living under stress. All those factors play a role. And that's when the muscular pathology has to be addressed just by analyzing posture. Once we analyze the posture, we go over it, we correct it by providing mirror imaging exercises to fix your posture. We have a baseline, we treat, we reevaluate to see the improvement. And then when it comes to the structural situation, here's 2 x-rays. X-ray on the left, normal healthy x-ray of the neck. One on the right, loss of curve. So what that does, it decreases your functionability of your central nervous system, brain blood flow, structural pathology that contributes to heart dysfunction, lung dysfunction. And then we also analyze stress view x-rays, looking at where things are compared to where they're supposed to be. When you get in a car accident of 3 miles an hour or faster, that causes ligament damage. That puts more pressure on your nervous system. And we analyze this because it's important to understand how pain plays a role when it comes to structural pathology. Another perspective of this, we're analyzing biomarkers of physiology to help you understand what can be done to fix the problem by analyzing the pieces that we do. And then if you think about this, when you have ligament instability, you're 40 times more likely to suffer with chronic conditions, including a decrease in velocity of the nervous system. This is what happens when you have structural pathology of the neck. Loss of curve, increase the pressure on the central nervous system, that yellow big image right there, and then in front of that, that red little line, that's your vertebral artery, that's your blood supply. And then the peripheral nervous system is also being affected, let alone arthritis, degeneration, disc herniations, just not good things happening to your system. And when this breaks down, it also affects how inside organs are also dysfunctioning. And we get that by analyzing your structural system and then how that works. So when your structural system is not where it's supposed to be, look at all the muscles inside your body that are affected. C1 out of alignment controls your headaches and all those green areas on your muscular system. When we get down to 5 and 6, spine pathology, which key indicator in car accidents, interferes with C5 and C6. It affects the thyroid. C6, now we have heart and lungs, and things that are being affected in COVID are heart and lungs, right? So once again, if your nervous system is constantly under pressure, that's putting your body under a state of stress, increasing the risk of not having a quality of life where you're supposed to be. That wraps up our show. Thank you for being here once again. Looking forward to our next show. A couple things to take home with you in terms of improving your health, like we talked about with Dr. John. Sit up straight, get outside, get some vitamin D, get some vitamin C, and also go see your chiropractor. Let your body function better because it can, because you deserve to be healthy, everyone.